Hi, everyone. We're so happy to see so many people joining us today. My name is Kate Oswald. I'm our Chief Policy and Partnership Officer for Partners in Health. And over the last few weeks, Partners in Health has mobilized across our 18,000 person network and our partners to pull together a treatment strategy and testing and treatment strategy. And so today we are so happy that we have three of our many experts with us who are going to talk through this strategy in more detail and offer time for questions. We'll have this available online for everyone who's unable to join today, and we hope that this is the first of potentially other sessions that we're able to offer talking a little bit about our strategy. So I'll turn it over to our wonderful experts. We have Dr. Joia Mukherjee, our Chief Medical Officer. We have Dr. KJ Seung, our TB expert, and Daniel Orozco, our Chief Clinical Operations Officer. So thank you.
Okay, great. Hi, everybody. This is Joia Mukherjee, and I'm missing all of you. I wish we were together, but I'm so grateful for everybody's support in their own homes and all the social distancing that we are trying to participate. And mostly, I'm grateful to many of our friends at PIH who are on the front lines as nurses, as doctors, as laboratory clinicians, as orderlies in our many hospitals around the world. PIH today supports 225 public facilities around the world. And we know that the folks that are cleaning and cooking and taking care of the beds, all of our staff really are on the front lines of this epidemic, many right here in Boston. So thank you to everybody who's trying to continue to take care of patients. We need to remember that millions of people will fall sick having nothing to do with coronavirus. So it's more important than ever that we continue to provide high quality of care for everyone, and that health is a human right and not just make this about epidemic control. That being said, I am going to use this word that everyone keeps using of unprecedented. This is an unprecedented time in the world, and we are really trying to figure out what to do about COVID. We're happy to report that as of right now, none of the countries that we work in seem to have widespread community-based transmission, except for the United States. And that may be because of a lack of testing, which is inevitably the case, but we also hope it's because we are early in those epidemics. And so our response at PIH to COVID-19 to support the sites that we work in, particularly in sub-Saharan Africa and the Americas and the Caribbean, is really to find cases early, to enforce and support humanely social isolation, and to treat and provide a high standard of care. So we're going to go to the slides now. And this one is very heavily text, but I think the highlight here is that we know that the most important thing is protection of the vulnerable. And one of our big concerns as Partners in Health is that when COVID, we don't know what's going to happen when COVID hits the poor, the poorest of the poor, children with malnutrition, people living with HIV, those suffering with tuberculosis, or our many, many patients that have lung disease because of tuberculosis. We expect that there will be a much higher fatality rate in the global south, as there always is, for multiple reasons: increased risk, the material difficulties of isolation and social distancing when you have to work every day to feed your family, the poor access to healthcare, the provision of high quality care, particularly intensive care, even things like oxygen, and then the impact, the large impact that these kind of global economic downturns, whether local or global, will have on the poorest of the poor. So we are vigilant about trying to look for COVID in the communities we serve and to provide and improve the kind of quality of care. That being said, we're doing all of that while we're supporting our sites on delivering high quality of care for everybody else. Next slide. So we have a specific approach to COVID, which is an approach that we have used in epidemics from Ebola to cholera to HIV to TB. One is to try to rapidly contain and control the spread of the virus in the countries and the areas, the regions that we serve. The second is, of course, what we are known for is to provide the highest quality of care that we can in a dignified way, and really to lead this effort with the idea that everyone deserved care. And then on the global front, we want to demonstrate to the world what aggressive action can look like in impoverished settings. We've seen aggressive action in places like China, South Korea, Singapore, and Taiwan, but we haven't seen what aggressive action can look like in a resource impoverished setting where it's even more important. And so that part of what we're trying to do is to lead and help governments to really execute on aggressive plans early. Next slide. So this is our four-pronged strategy to massively expand the access to testing. Right now, the test is, as many of you have heard, a real-time PCR, and we'll hear more about the implications of that from our laboratory expert and Chief of Clinical Operations, Daniel Orozco. But that test is done only at centralized national labs and has a turnaround time of 24 to 48 hours. So one of our responsibilities in this test is to rapidly expand rapid testing. Why rapid testing? We will get to that later, but we think the most important thing is to find each and every contact, anyone who may have coronavirus, and institute humane isolation so that so with testing, we will be able to control the epidemic. Second is treatment, a high quality of care. We are very fortunate to have our Chief Medical Officer of PIH Sierra Leone right now in Brazzaville on behalf of PIH with the World Health Organization Afro region, training people from ministries all over Africa to provide the highest quality of care for patients with COVID. And we will continue to support the implementation of oxygen plants. We have oxygen generators in every country we work in. We're making oxygen. And we know that most countries don't have any oxygen facilities in impoverished settings. So that is something that we're continuing to work on. We have oxygen concentrators, oxygen generators, and we will be working on that. We are considering what to do about ventilation. We already have some sites that are capable of using mechanical ventilation, but again, in many of these countries, there are no ventilators. The third is about tracing. We feel that we have a huge advantage in the fact that currently we have 11,000 community health workers around the globe, and they can be rapidly deployed to do contact tracing. We've done that in cholera, we did that in Ebola, and I'm thinking now particularly about our amazing colleagues in Haiti. The day that cholera was recognized in Haiti, I talked with our head of community health, Dr. Ralph Chernier. This was in the cholera epidemic, and he said, I tell you what I need. I need this, I need that, I need bullhorns, I need education cards, and we're ready to go. So we have a network of 11,000 people who are ready to go and to protect their neighbors. They've done it in Ebola, in Sierra Leone, Liberia, they've done it in cholera in Haiti, and of course, everyone has done it with HIV and TB and other infectious diseases. So that community health worker group will be tasked to find contacts, to help support social isolation at the home, and even to do rapid testing. And then lastly, we want to accompany ministries of health with a long-term plan. And I'm happy to report that many of our sites have learned so many things about public health and global health delivery. I was in West Africa just 3 weeks ago, and when I went into the airport, both in Lungi and Sierra Leone and in Monrovia, I was screened. my temperature was taken by people with masks. Hand washing was enforced at all points of entry. And that was now almost a month ago. We still don't have that in the US. So happily, there are some great lessons being learned throughout the world. And I think we've got great governance in many, many of the countries we work in that really believe in science and want to get ahead of this, even if it means trying to use every tool at our disposal to do this. Next slide. So please go to our current COVID-19 guides. Partners in Health has made a two-part COVID-19 guide. These are based on ministry recommendations, WHO recommendations, CDC recommendations, and then also our 30+ years of experience on executing and delivering on global health projects. Part 1 tells you about testing, contact tracing, and community management, and Part 2 is the evolving knowledge on the facility-based management and care of people who are quite sick with COVID. You can download these guides in real time. The current ones are dated March 19th, but we will be updating them daily, hourly. And so if you don't get what you need, you can reach out to PIH and we can make sure that your questions are responded to. Next slide. So I'm going to turn this over now to my colleague KJ Seung. KJ is a global expert in infectious diseases. His work has been particularly concentrated on tuberculosis, but we're very fortunate that KJ has worked extensively in North Korea, and because of that has gotten to know much of the Korean medical establishment in South Korea. And South Korea provides an amazing example of what to do right in testing. And so KJ's been leading our response, trying to really massively expand access to testing. So I'll turn it over to KJ now. KJ, are you on mute?
Hi, everybody. I think a lot of people have seen this slide. This is from the Korea Centers of Disease Control. Really, there is really within a short period of time, there was a major outbreak, and but an equally rapid control of the spread of transmission. And I think that this has shown the world, and there are other countries also like China and Hong Kong and Singapore that have shown the world that control is really possible, and that mitigation is just mitigation by itself is not enough. And I think that that is really reflected in some of the things that came out of the recent WHO press conference, where Tedros stressed testing, and that without testing, you're really flying blind. Next slide, please. So we really want to have much more access to testing, all sorts of testing, both the rapid tests and then also PCR. We want, right now, I think most of the country's strategies have been focused on screening travelers, which certainly is a good idea, but it's not enough. And I think that the experience from a lot of countries have shown that community transmission can start very quickly, and unless there is some very good surveillance, you're not going to be able to pick that up. And we are worried about nosocomial transmission from undiagnosed cases in our healthcare facilities. So next slide. We are, and I think that Daniel can talk about this next, but so these are what we are going to be rolling out in the next couple of weeks are the rapid diagnostic tests. And these are commercially available. In fact, they are being widely used in multiple countries already. And I think that it's important for PIH, but a lot of organizations that are on this call to figure out the best way to use these new diagnostics. Daniel, do you want to talk a little bit about both the antibody and the antigen rapid diagnostics?
Sure. Thank you, KJ, and thank you, Joia, and hello, everyone, and thank you for joining this conversation today. We are definitely very excited about the opportunity to share our strategy, but also the preparation that we have been doing through the last couple of days in terms of testing, in terms of responding to one of our core objectives, which is primarily focused on the testing strategy. There have been a lot of research done in terms of looking for the test, what is available in country, and what is not available as well, and what is in the pipeline. I think our approach aims to be comprehensive. We are not only looking at what to do at periphery, in district hospitals, or in health centers, but also looking at the national scale, what we are able to do. So we are working at the different levels of the pyramid in the health system, and trying to address the gaps in those in terms of diagnostics. At the periphery, where PIH is primarily engaged with the ministries of health, working at community level and district hospitals, our strategy is to roll out rapid tests. And now we know there might be a lot of questions around that, and we are definitely working on clarifying that in our clinical guidelines. And Joia will touch a little bit on that a bit later. But there are two types of tests that we want to roll out in the periphery. The first one is an antibody test, and we know there is a window period between the infection and the day when symptoms start appearing, and the IgM or IgG will start showing up in the rapid test. For the IgM, which is the earlier antibody response, we have about 7 days after infection. And again, we know that there are questions about that in terms of how useful is this test for screening patients or for contact tracing, and we're gonna get into that. But it's a tool, as KJ say, that we are already seeing being rolled out around the world. It's a tool that has been used earlier in some of the countries with a high peak in the epidemic, like China and other countries in the Middle East, in Europe. Even here in the US, there are a lot of manufacturing plants already working on the IgM, IgG rapid diagnostic tests. For those who are familiar, and I know we have probably a group of the lab managers and lab teams on this call today, everybody is familiar with how to perform one of these tests. It's a very simple rapid test, finger stick, whole blood, that will be read in 15 minutes, and is very similar to many of the other rapid tests that the lab team or the nurses perform at district hospital. The next slide shows also the other type of rapid test that we are aiming to roll out. This is an antigen test. And again, we will talk about the PRONCH approach on how we are delivering this to the sites. This one is on nasal or pharyngeal or sputum, pharyngeal swabs or sputum. It takes a little bit more preparation in terms of the specimen collection, first of all, making emphasis that we are providing the personal protective equipment for all the personnel at our sites that are going to be performing the test, taking the specimens, reading the test, and working really closely to the patient. So that's really a central part of our strategy. Again, it's a rapid test that in this case provide 2 lines, control and test, positive, negative, which is read within 15 minutes. That's our first level of the testing strategy. Again, that doesn't mean that we are not looking at the other levels. We continue looking at molecular capacity. We have been working, and it's core to our approach at Partners in Health, is to create capacity at our sites, and we are looking into technologies that we already have in place, like the GeneXpert instruments, looking at the cartridges that are coming out of the pipeline in a few weeks from now, but also working with the national labs to look at their PCR platforms for us to be able to support what is being done, B, provide technical assistance, C, looking into providing reagents if it's required of equipment, so that we have a more comprehensive approach to the testing strategy. So that's where we are today, working with manufacturers and really speeding up the process of procurement to be able to deliver these tests on site. So I'm going to turn it back to Joia to tell us a little bit on the clinical side. What is the algorithm? How are we going to use these tests at the periphery level?
Yeah, so you know what we're talking about. Thank you, Daniel, and thank you, KJ. I think those were excellent explanations, and we'd like to make this really as simple as possible because we know everybody's feeling so overwhelmed by this, and so the idea is really to test a lot of people, and particularly what we're supporting on governments on is the entry points, as KJ has said. But we also, in terms of partners and health sites, we think the major hospitals are very big priority because people are sick in the hospital, people are vulnerable in the hospital, and we can control the doors. And so what we feel that is our responsibility is to keep a safe working environment for our staff and for the patients that are in our care. And so we will be prioritizing testing of anybody coming into the screening of anyone coming into the hospital, and testing for those who meet a positive screening of the case definition. And then trying to, as the epidemic advances, really separate people out, even in the triage area, as we did with Ebola, so that we can make sure the nurses, the physician assistants, the medical personnel, and all the cleaning personnel have the proper protective gear in the areas that they have the most highly suspected cases that come in first into triage, screening, testing, and then into an isolation ward. So we really want to try to stop any nosocomial or hospital-based spread. That was something that we saw cause very high mortality in the Ebola crisis. And so we really want to prioritize facilities where we work. Next slide. We also, of course, Partners in Health has always had a very important commitment to prisons and other congregate settings. And I know our team in Peru right now, because of tuberculosis screening, is working in more than 85% of the prisons in the country. And so as soon as we're able to get those tests in hand, we know, unfortunately, around the world, prisoners particularly, and often the elderly as well, are last in line to receive innovative services and services that can keep them safe. And so we're very, very committed to focusing on congregate settings. We also are very fortunate, because of our huge network of community health workers, that they will know where the big congregate settings are. We know there were some very big spread, particularly the story from Korea in a mega church. And I think our community members know when those sort of where those high congregate churches or evangelical outreaches are happening. That is not uncommon in many countries, and we want to, of course, target that. And then we are working, as I mentioned already, with the governments to support the screening of travelers. And so far, in the countries we have heard that transmission is occurring, and I'm particularly now thinking of the excellent work with Dr. Maxa Luma and team in Liberia, and with Joel Mulabigi in Rwanda, that both of those countries, the first infection was identified through a traveler, which is not at all unexpected. And same in Peru with Dr. Leoleka. So travelers, airports, and some of you may have seen the post on social media with our amazing heroic nurses in Peru that have been among the group of people deployed to the airports and borders in Peru, and so proud again of our frontline providers who are putting themselves in harm's way for the greater good. Next slide. This is the testing algorithm. It's a little busy, but who are the people to be tested? There are really four groups, right? One is contacts. and contacts of people with documented COVID-19, that will be through a contact tracing team, and we're working with governments on who that ought to be. Right now it's known contacts, but it's also travelers, and most countries have implemented any travelers coming from places that have COVID will be self-quarantined, and we hope to be able to test them more rapidly. The second is inpatients and outpatients coming to our facilities, which I already mentioned. The third is we're hoping to do some screening of asymptomatic health workers in high patient flow areas, because we know health workers can, are at very high risk, and we've seen that around the world. And then, as I mentioned, the large outreach. As you go down, what would we find for a positive? Obviously, a positive test for anyone would be isolation, and they will also get a rapid PCR. I think I'll go to the flow diagram we made this morning to make that more simple. So next slide, can we get to that, and then we can go back. And so this is I think in some ways a simpler slide. Maybe it's because I made it so I can walk through it, but maybe it's the colors. Here is the thing. On the blue box at the top, what you see is screen for symptoms. Where that happens doesn't matter, right? It would happen within the contact tracing network. It could happen at an airport. It can happen at a facility. We screen for symptoms. Does the person have fever? Are they short of breath? Do they have the flu-like aches and pains? Or do they have a risk? They're coming from a high prevalence area. They have a known contact. Well, if all of that is no, well, they're like you and me right now. Social distancing, working as much as possible from home, or if not from home, to maintain a safe distance. If they have either symptoms or known contact, they will be put in immediate isolation, and that's what's happening. And that might be self-quarantine, but it is isolation nonetheless. And in that isolation, they'll be seen by health workers in PPE, personal protective equipment, to do the oxygen saturation, to do vital signs, to do those basic things which will let us know, is this person sick or not very sick? If they're sick, they will be admitted to an isolation ward, and we're working with teams and countries to say, where will those be? In some countries, it's the military hospital. In some countries, it's a Partners in Health facility like the Mirabelais Hospital. So we will be working on making sure that those isolation wards for sick patients are safe, are stocked, and wherever they are. It doesn't matter if it's a Partners in Health site or just what the government wants to do. That's the notion of accompaniment of the government. If they don't have criteria for admit, but they have a high suspicion, symptoms, or known coming from an area, they should be in home-based care, which is really a quarantine, but we don't want to call it quarantine because there's care in that. It's hopefully food support, people checking in on them with a safe social distance, and continuing to keep an eye, monitoring their temperature, how they're feeling, in case they start to fall ill, and then they would be admitted to the isolation ward. So meanwhile, on the right side of this slide, what we have is the testing strategy. So as you can see, the immediate isolation happens regardless of a test. So the test doesn't help us to decide on isolation. If someone's sick, they need to be isolated. If someone has a risk, they need to be isolated. But where will the rapid test help us? Well, first of all, the rapid test, whether it's an antibody or an antigen, that's enough confirmation to rapidly activate the contact tracing network. And that will be looking at how many, because people, they could have been asymptomatic for even up to 14 days. So we've got to say who were the close contacts of this person, and knock on doors and do an assessment, a screening assessment. Does this person have a fever? We're hoping to get more and more of the infrared thermometers out there. Are they feeling ill? And then making sure that they are doing home-based isolation. And I would say they become a suspect case if they have symptoms and a known contact. Everyone who's put in immediate isolation will also get a PCR. That's the national protocol. We're not doing anything different than the national protocol. We're trying to add with the rapid test something that can allow us to start really right away in contact tracing. Once the national lab gets the PCR, that's about a 2-day turnaround time now. Now, as things ramp up, the turnaround time may even be much longer because the machines will become overwhelmed. So you can see the need for the rapid test is going to become more and more apparent as we progress. And the national lab, once that PCR is positive, they will also activate the contact tracing network. Now, the other issue is there will be a clinical case definition, regardless of test, because as this becomes a more common phenomenon and the teams are working with sick patients, some of them will just meet the clinical case definition for COVID-19. And we know that's happened in China, that there are many people that never had a definitive laboratory diagnosis, but they're reported as COVID cases because they had the symptomatology that looked like COVID. So once we have those people that are highly suspicious, even if unconfirmed, that will be put into the contact tracing network as well. So as you can see, the test doesn't really help us with isolation, with treatment, but what it does help us with is really ramping up the case finding and contact tracing. And that is the key part to breaking the cycle of transmission and lessening the suffering. Next slide. So we are also working on a facility-based treatment guide, as I mentioned, and it's about preparing and managing the facility. It's about the infection control flow that needs to happen. It's about the clinical management of patients with COVID. It's about the occupational health. Many of you have heard now that as our health workers are getting exposed, they need to be put on furlough, and there have been general shortages. So we have to make sure that we're taking good care of our providers as well. And then our mental health team has done a lot of work with teams around the world on what mental health and psychosocial support, from material social support to the actually more psychotherapeutic social support. This is a very hard time for everyone. Next slide. This, I think I walked you through to some extent, but for people who are interested in more detail, at the top you have a patient arrival. The first screening takes place at a designated point of entry. That is now currently in many places in the world a tent. And the questions are symptom screening and COVID exposure. And in many countries, again, that COVID exposure may just only be coming from a country with documented high-level COVID transmission like ours in the United States. If no, they can go for routine checking, because remember, a lot of people might be coming to our facilities for other things, for broken legs, for delivery of an infant, pregnant women. So we want to make sure that routine care can go on, but go on safely for the staff and the other patients. So if that screening is yes, and you saw this in the previous slide, the patient will be given a surgical mask and sent to a secondary screening area. Okay, in that secondary screening area, that's when we might decide on the test, using the test. Well, that's when we will use the test. And if the patient has clinical symptoms, they will be moved to an isolation area for treatment. So this walks us through, if they don't have respiratory symptoms, they may continue to wear a mask. And we'll see about continued routine care. And I think that's going to be the question about what to do with those patients that are a bit in the gray area. Next slide. So I'll turn it out to questions or to my colleagues to add stuff in. And please, chime in with questions on the chat, or Daniel and KJ, please, or Kate, please jump in.
I would just add briefly, Joia, a small detail, and it's that it's not a small detail. It's an important piece of the whole rollout strategy. Is that we are also using this opportunity of rollout to work with our colleagues at the sites and with the national labs to collect data. Data is important. We want to make sure that we collect the evidence, not only at centralized labs. We are working here in Boston, for example, with a couple of colleagues to help us compare the rapid diagnostic test with the PCR, but also we want to do that at the sites, and the sites are invested on this effort. We want to collect the evidence. We are advocating and lobbying with WHO and with the CDC Africa to do this, and we are getting a lot of buy-in and support for this effort to get really the data on the rapid diagnostic testing performance. So this is part also of the strategy. It's not only for the guidance on the clinical piece, which is the most important component, but also to accumulate evidence to submit to globally. Thank you.
Great. Also, question came up from Maxo Luma, who's listening in. Hi, Maxo. And what he is saying they are talking about in Liberia is precautionary observation centers. So I think that's a reasonable thing for countries to do, and KJ may be able to add more, but in some of the Asian countries, they have had fever clinics. So people who seem to maybe have COVID, we're waiting for the response, we're putting them in a precautionary observation center. Hopefully, as we see more information from rapid tests, we might be able to have fewer of those, but I think it's a good idea. I don't know if KJ, you want to comment on that.
No, I don't have much to add. I think we're all thinking about it. I think that it also depends on the epidemic and the status of the epidemic and the prevalence in the community, which is going to be, we know is not going to be uniform across the entire country. So certainly, we're hoping that one of the major reasons that PIH is pushing widespread, much more widespread surveillance is so ministries of health can get a better understanding of where are the hot spots. So if there are certain hospitals that are clearly having a lot more patients, then yes, a lot of these things that Maxo and Joia are talking about in terms of streamlining and separating out suspects, they need to be implemented as soon as possible.
Yeah, thanks. Other questions, comments?
There are a number of questions that are coming in. I might just read them and you guys can respond.
Sounds good.
Is domestic travel safe for the next couple of days in the US?
I would say no. I mean, the part of the issue with social distancing is we just have to do it, and we all know what travel looks like. It's not possible to be 6 feet or even 3 feet from another person on an airplane. And so I think if you're trying to reunite yourself with your family, or you have some very important reason to do it. But I think part of the problem, and if you can go back to that rapid test antibody slide, whoever's running the slides, go back. Yeah, go back. Go back. Yeah, stop there. So here's the problem, guys, right? You have an incubation period of 14 days. So when was the last time I had in touch with a lot of people? It was Friday. I feel fine. I suspect I don't have COVID. But if I get on a plane today, I could be infectious. And the thing is, so could a lot of other people on that plane. And I have to really be basically on my own for the next, with my family in my case, and my dog, who we hear actually are not infectious dogs, so that I don't spread this virus. And so I think it's important to remember that this 14-day window of incubation period, one can be infectious during that period. So this social isolation thing has to be minimum 14 days from your last contact so you don't spread the virus. I mean, I'm at home with my son and my mom, okay? And any one of us actually could be shedding virus, right? Any one of the 3 of us. So, okay, we've made the decision that this little pod might get COVID. but we're not spreading it to others, nor are we letting any other asymptomatic people come in. So I would not get on a plane. I would absolutely minimize grocery shopping. I would, until we see that the cases are actually coming down. The last time I got on the 39 bus to go up to the Prudential Center, I touched a pole just to get off, and I thought, uh-oh, right? I mean, this is thousands of people are touching that. So, I mean, I think we have to be just exceptionally cautious, as this is the only tool we currently have in the United States. Testing is not widespread. So I think the only thing we can do right now is social distancing.
Thanks, Joia. Fernay asked, should we wait the window period for patients to be symptomatic to do the rapid antigen test?
I would say no, Fernay, because my view is we should do the rapid antigen because we don't know enough about this disease. People might be positive. There are likely asymptomatic positives out there, and we'd want to know so that we can test their contacts. So I would do the rapid antigen test. That doesn't mean I wouldn't do the PCR, right? If we think someone might have COVID, we should do the PCR. We shouldn't think any one test is going to tell us. The most important is history, travel, known contacts, and clinical suspicion. Those are the diagnosis that we have to make to institute isolation. And the test will only be additive, but we can't be reassured by a test in the window period. But if it's positive, it's helpful. Does that answer, hopefully, your question?
Great. Another question is, have we looked at non-conventional ways such as 3D printed materials, like what they've done in Italy for ventilators to get equipment to people?
Great question. No.
We haven't, but we will. I think it's a good idea. And thank you for that recommendation.
Another question, what is the status of the rapid tests? Have they already been distributed to sites?
So we are in that process. We started the procurement process already late last week, about Thursday, Friday. As you can imagine, there is a lot of demand, and there is already global shortage in many cases of even of the rapid tests, not only the PCR tests that are also in shortage right now. So we are working with the 2 different manufacturers that we have selected to coordinate the payment and the shipment to the sites. We have determined the volume of testing that will go to each of the sites, and we have been in contact with our executive directors. So there is a process already ongoing, and our expectation is that the test will be arriving in the next week to 10 days to the sites. So that's ongoing.
Great. Hopefully that helped answer that question. Here in Lesotho, we have DRTB treatment hospitals, and some of the symptoms overlap with TB. And it's really very important for us to have the kits as soon as possible so that we can get patients co-infected from South Africa. That's a comment.
Thank you. That's what we want to do. I'm so worried about Lesotho, given the high prevalence of HIV and TB. I think that's just so unknown. We have to really get on that. I think Paul asked a question about lopinavir, ritonavir, and remdesivir, and chloroquine, and PPE, and all the supplies, the stuff. We are working diligently on all of those things. Unfortunately, there are shortages even in things like chloroquine. So we are trying, but this is an area that the global demand is way ahead of us. Daniel, do you want to add anything to that?
No, I mean, what you say is correct. It's been hard to get like even details from some of the manufacturers and suppliers to be able to not only buy the test, but there is already problems for shipments because countries are closing their borders and we are having less and less alternatives to distribute the test to our side. So that's why we decided also to speed up this process and really make sure that we have the testing on site. But we are facing challenges around that, not only the rapid test, but also our regular supply of medicines, PPE, etc. So it's a challenge, but we are navigating through it.
So there are two questions on the chat that I'd like to address about spread of COVID and social distancing. And I'm going to be on a webinar later to talk about this too at 8:30, so you can tune in. We'll send the details around. But somebody asked about how would COVID spread when people are asymptomatic, not coughing and sneezing. The thing is, the second question that's related to this is about conflicting ideas of social distancing. International guidelines are 3 feet or 1 meter, and we're often using 6 feet. So these are sort of related answers. So first of all, you can be shedding virus asymptomatically. So obviously, if you're coughing or sneezing, you cough and sneeze into your hand, you shake hands or touch something, the virus can live on surfaces for a few hours, right? And so you can be shedding them from an allergy. You know, I'm an allergic person. I rub my nose. See, everyone's grossed out, but luckily you don't have to touch me. So, and then I can touch a surface. So the asymptomatic shedding can happen just from, your nose running, can happen from, whatever is in your mouth, can sharing utensils, things like that. Contact, this is a droplet infection. So droplets from your respiratory tract onto your hands is how it's spread most of the time. The reason 6 feet, I think, is a better recommendation than 3 feet is because we do not know if this is airborne. So far, we're saying it's not, but our great colleague Ed Nardell, who may be on the phone, who is an infection control specialist around the world, has worked on TB all his life, he feels there's probably an airborne component. If there's an airborne component, that means that the droplets kind of float in the air. And that's why we're kind of being more conservative and saying 6 feet, even though that's not a perfect solution either, because in tuberculosis, those droplets can kind of stay in the air. So I tend to be more conservative on the 6 feet is, because if someone coughs or sneezes, you could in theory inhale the little droplets. And that's why 3 feet is recommended. 6 feet is more conservative, but I think reasonable because there's so much unknown with this virus.
Just a small detail, Joia. 6 feet is about 1 meter 80 centimeters.
Yes, I knew that.
It's about.
So it's double, almost double. Yeah.
There are a number of other really great questions. One about, from our PIH experience, recommendations for communities where sometimes the primary contacts for patients are traditional healers and possible collaboration with community and primary healthcare workers.
That is such a great question. I mean, I think, again, the strength of PIH is our community reach, and so everybody has to be on board, including community healers, and we want to make sure they're protected too. They have enough knowledge, and they are we know caring for a lot of the needs of people, whether they're spiritual needs or other traditional needs, and so we want to make sure that they often are also frontline providers of different sorts of care.
Great. Another question, what is our take on warm weather as a protective factor? Obviously, this isn't true for TB and plenty of other respiratory pathogens, but would appreciate any insights.
KJ, do you want to take that one?
I think, as Scott is saying, we just don't know. And but I think that most epidemiologists are saying we certainly cannot count on that. This is not like the flu. There isn't any immunity within the community already. So it's very difficult and probably really dangerous to extrapolate from other infectious diseases. And so I think what everybody's saying now is do not count on any automatic mitigation as we get into summer, and we really need to pull out all the stops and try to control the disease and the spread of transmission.
I was in Colombia about 10 days ago, and there were no cases. It was about 30 degrees Celsius, and today there are over 70 cases in the country. So I think the weather is showing that it's not really influencing the spread. We see more and more in the countries where we are working that the cases are increasing. So we shouldn't, as KJ say, just rely on that the epidemic will stop just because the weather is changing.
Another question from Liberia, considering production of oxygen, are we producing oxygen in Liberia? If yes, how can hospitals across the country access it? Given Liberia's position on the availability of test kits, is PIH considering making sure the RDTs get to Liberia to facilitate rural contact testing?
Yes, definitely. So we are working with our colleagues in Liberia to make sure that the RDTs are reaching not only the facilities where we are working, but also communicating with the Ministry of Health to be able to coordinate a response also at other sites, including perhaps the airport or the borders. On the oxygen piece, we are also looking into that, and we are working on getting some oxygen concentrators which we are distributing to the sites. So I actually been working with our procurement team, with Jesse Greenspan, our director of supply chain, who is coordinating with the sites and really making sure that there is oxygen availability at the site. So it's a coordinated response on that as well.
We've also been getting some comments about the importance of starting to roll out training for testing strategies now, so that when the rapid tests do arrive in countries, that everybody will be ready to go. Is that a next step that we're considering?
Yes, absolutely. So we are including in the guidelines, we have SOPs, and we have some job aids already produced or available from the manufacturers. And our lab team is coordinating several webinars for lab managers, but also for nurses and other managers at the facilities to make sure that we transfer the knowledge on the performance of the tests, the collection of specimens, the interpretation of results, and the recording, the reporting to the clinician. So there is going to be a series of that, and we will probably circulate those links in the next 24 hours for people to be able to join into these webinars. These are about the test performance itself. I think that there will be some ongoing webinars also in parallel about the clinical guidelines, which our clinical team is producing under the leadership of Joia and KJ.
Yeah, I mean, one of the questions about oxygen, this is a really critical question. So, and we're going to get some guidance across our clinical team. So with oxygen, there are essentially four things we can do, right? We can give oxygen by nasal cannula, and that means the oxygen flow can't exceed 5 liters a minute. Most of our oxygen concentrators only can produce 5 liters a minute. So that will work with people who have some mild oxygen need, but not a lot. Then we have the face mask, a simple face mask. A simple face mask can work up to about 5 to 10. Once you need that simple face mask, you really need either a 10 liter per minute oxygen concentrator, which we generally don't have. We have the 5 liter per minute, or you need an oxygen tank. And then for the non-rebreather, which is the third level where you can get slightly higher flows, you need the oxygen tank. Also, once you have ventilation, so the fourth stage is the mechanical ventilation, you can't do that with oxygen concentrators, obviously. You need tanks. And so, or wall circuitry. So I think we have to really think about what the implications of what kind of oxygen. We're very fortunate in many countries, we have oxygen generator plants that produce the tanks. So we can use that for the first 3 phases of oxygenation. But with the concentrators, most of the concentrators we have will only be useful for people with mild oxygen requirements. So we're going to have to really think that through with our clinical team on how to use the oxygen concentrators versus the tanks.
Thank you so much, Joia. I know there's so many other questions. I'm going to leave time for 2 more but we won't be able to answer all of them. Hopefully we can answer them via the chat option. But one important one that came up around social distancing in rural contexts, how do we ensure that strategy in places where there's food insecurity issues and other concerns?
Yeah, this is the most, I think that was Fatima's question. Hi, Fatima. This to me is one of the most critical aspects in every country, including in the US, but we need to figure out what and we're going to look to all of you to say, what is a reasonable package of support that we can provide to people who need to be in isolation at home, and try to find money for that and really provide food, water for people, because otherwise there is no way that isolation can happen. So I think putting together some ideas from each site to say, what can we do? What can the community do? Is just critical. And then hopefully our community health workers would be able to deliver those things or try to figure out a way to support people. You know, here in my town, which is a very affluent town, there are central places where there's like grab and go lunches for people who need the food for their children. But I mean, this is going to be one of the biggest problems.
Absolutely. And I think in all of what we're saying now, you know, a lot of our PIH colleagues are on the line, which is really wonderful. I think we want to emphasize as well the importance of ensuring that after we conduct our trainings for our own staff, that our Ministry of Health colleagues at the central level, at the district levels, at the facility levels, that we're doing this in partnership. And we're offering and able to share these resources with anyone. The idea of having this live webinar that we could then record is that people will be able to share it with your colleagues, and it has access. It shows where you can access the guides as well, and hopefully we can also offer additional webinars over the next weeks that ministry, that anyone, implementing partners and others can join in on. I realize that we are at time. Do you all want to offer any closing remarks before we head out?
Nope. Thanks everybody for tuning in, and let us know how we can be helpful. We can't wait to get these tests. We can't wait to really try to help stop the transmission before it gets widespread.
Yeah. Thank you so much.